Hello class, we're covering here in this particular lecture, chapter 4. This is the shoulder complex. We're going to cover structures and function. Here we have an opportunity to look at the shoulder complex and the different joints that are surrounding the joint. So we have the acromioclavicular joint, your glenohumeral joint, your sternoclavicular joint, as well as the scapulothoracic joint. The sternum, it's located just anterior, okay, at the thorax, at the midpoint there of the thorax. We also call it the breastbone sometimes. All right, it is with some additional pieces to it in terms of the sternum. So you have your manubrium, you have the body as well as the xiphoid process. And so the manubrium is the most superior of the three mentioned, and it's going to articulate there with the clavicle. That's going to make the sternoclavicular joint. Then your body, this follows the mid portion of your sternum, and it has an anterior attachment that's going to be the point for the ribs 2 all the way through 7. Your xiphoid process has the inferior tip, and that's going to be there at the sternum, and that xiphoid basically means sword-shaped. What we have here is an opportunity to take a closer look here at the sternum here. And so you see the anterior view of the sternum. The left clavicle, as you're looking straight ahead on, the left clavicle and those ribs have been removed. And what we see is the proximal attachment of any of the surrounding muscles that attach to the sternum itself. And so we have, you just want to take note, you have the pectoralis major, all right, that originates from here on the manubrium and also the body of the sternum. And then you have your your subclavus muscle. We didn't go over that one per se in intro, but just take note of this there. And you also have a portion of the sternocleidomastoid that also attaches to the sternum, more specifically the manubrium. All right, let's take a look at the clavicle here. The clavicle is S-shaped and it links the scapula to the sternum. The clavicle has an acromial end as well as a sternal portion. So when we talk about that acromial end, it has more of a flattened lateral part to it, so it's more flattened, and that's going to articulate with the scapula, and it's going to form the acromioclavicular joint. Now you remember the medial portion of the clavicle. That one is more at the sternum, and so that's going to go ahead and articulate with the manubrium, and it's going to form what we call our sternoclavicular joint. Here we have an opportunity to look at the superior surface of the clavicle as well as the inferior surface of the clavicle. And so you just want to see that with the superior view of the right clavicle, specifically in this picture. It is with the sternum, and you can also see its attachment here where it's articulating with your acromion too as well. You have your proximal attachments of the muscles, those are shown in red, and then you also have your distal attachments. Remember, those are shown in green. So your red are going to be your where it originates, and then the gray is going to be your insertion points for your muscles. And you just want to take note. So we have the portions of the pectoralis major and sternocleidomastoid in terms of those that originate, as well as the anterior deltoid. All right, and then in terms of insertion points, the upper traps do tend to insert on the acromioclavicular end. Now with the scapula, let's take a look at that. The scapula has a very nice triangular shape to it. We like it. It's very, very highly mobile, and it rests on the posterior side of our thorax. There are two fossas relative to the scapula. You have your subscapular fossa, and you also have your glenoid fossa. The subscapular fossa has a slight concavity to it in its anterior aspect of the bone. And that's going to allow it to just glide very smoothly along the posterior rib cage that has this convexity into it in its shape. Then you have the glenoid fossa. The glenoid fossa is slightly concave, and it's going to be oval shaped in terms of the surface, all right, relative to the humerus. And that's what's going to comprise our glenohumeral joint. Here we have an opportunity to look at a schema. This is a schematic of the posterior view as well as the anterior view of our scapula. And so reminding you, in red, these are your originations or your proximal attachments and then of muscles. And then in the gray, you'll see those are going to be your distal insertions of the muscles. So just taking note of the supraspinous fossa, you have the supraspinatus muscle that sits there. Your infraspinous fossa, you have the infraspinatus muscle that sits there. Dividing those two, which is the spine of our scapula, okay, that spine of the scapula houses the origination of the posterior deltoid, okay, the acromion more so for the medial portions of the deltoid. Also on the spine of the scapula, take note that you have the insertion points for the lower and also the middle trapezius that's there on the spine. All right, and if we look at the borders, the medial border and the lateral border of the scapula, you have at the medial border insertion points for the rhomboid major, also you have for the rhomboid minor, and then going up more superiorly, we're going to find that you have your insertion points for your levator scapula, right there also through that superior angle and border. And then at the inferior angle of the scapula, you'll see that this is an origination site for the latissimus dorsi as well as the teres major. The lateral border of the scapula houses the teres minor muscles. When we look at the anterior view of the scapula, so that's the picture off to my right, what you'll see here in that subscapular fossa sits the origination for the muscle belly of the subscapularis. Right, you have where you can see the medial border allows for your serratus anterior, okay, to have their insertion points there. And then moving out lateral, okay, on the lateral border, you can see moving towards the glenoid fossa, but still part of the lateral border in the superior portions, you have the long head of the triceps, all right, on the infraglenoid tubercle there. All right, you can also see your glenoid fossa too as well. And then your coracoid process, we're able to look at that and see the origination points for the short head of the biceps and the coracoid brachialis, as well as the insertion point also on the coracoid process for the muscle that is the pectoralis minor. And we can have a better appreciation of the medial origination point for the medial deltoid, as well as more so into the clavicle itself, that you can see the anterior deltoid attachment there too as well. Okay, here we have an opportunity to talk about the supraglenoid tubercle. Well, there are two tubercles. You have your superior and your inferior glenoid tubercles. And so what these do is they border the superior and the inferior aspects of the glenoid fossa. And these are very nice in serving as attachments. You have attachments for your long head of the biceps and then also your triceps as well. The scapular spine, that's going to divide the scapula's posterior aspect into a supraspinous fossa and an infraspinous fossa. Also, as part of the scapula, we still talk about another feature, the acromion process. And so the acromion process, I know you remember this from intro, it's wide, it's a flattened projection of bone, and that's going to be on the most superior and lateral aspect of the scapula. So you'll want to keep that in mind because we're going to do palpations to be able to find and locate the acromion process. And so you want to remember that it's this wide flattened projection, and you're going to find it on the most superior as well as the lateral aspects of the scapula. The acromion process, it forms a functional roof over the head of the humerus, and it's there to actually protect all of the delicate structures that are housed underneath its roof there. Other parts that we have for the scapula are the coracoid process, and this is a finger-like bony projection. We find this on the anterior scapular surface, and so it serves as an attachment site for lots of muscles and also ligaments of the shoulder complex. You have the medial and the lateral borders of the scapula, and so when these two borders, the medial and lateral borders, meet together, it forms the inferior angle of the scapula. And a prior slide, I talked about that inferior border of the scapula. We have the origination point of the latissimus dorsi that's there. Okay, and then you have a portion of your teres major also originating there, and then also moving up the lateral border of the scapula for your teres major. But that inferior angle, it's important in tracking the scapular motion. So when we are looking in terms of understanding upward rotation and downward rotation, your point of when you're looking at the body to see if the scapula is going up in terms of rotation or down in terms of rotation, use the medial, use the inferior angle that is created from the medial and the lateral borders of the scapula. So you can palpate the medial and lateral borders of the scapula and bring it down until it hits that point of the inferior angle. And then watch your patient's arm as they move the glenohumeral joint up or down the scapula. Does it rotate up or does it rotate down? Well, your inferior angle will give you that understanding of whether it's going up or down. Okay, we're going to move the conversation away from the scapula and just lead down a little bit more, where we're talking about now emphasizing the proximal to the mid-humerus. Let's have some conversations about that. The proximal humerus, that's going to be an attachment point of lots of ligaments and muscles, and it also links the upper extremity to the actual shoulder girdle itself. Then you have your humeral head, and so nearly 1.5 of a full sphere of this articulates with the glenoid fossa, and this is what comprises our glenohumeral joint. Part of the proximal and the mid-humerus are also other structures that we want to keep in mind. And so you have your lesser tubercle, as you guys remember from intro, and you also have your greater tubercle and your intertubercular groove. Now, when finding the lesser tubercle, we remember that it's sharp. It's also the anterior portion in terms of its bony projection, and it's just below the humeral head. Okay? The greater tubercle is larger and it's going to be more rounded. And you want to take note to remember that it's more lateral in terms of its projection of the bone. So when we do palpations and we're looking for that lesser tubercle and we're looking for that greater tubercle, it's important to remember that that lesser tubercle is going to be more anterior when you're dropping off the acromial joint there. You're going to find more anteriorly that you're going to find that lesser tubercle, and then more to the lateral portions, you'll find the greater tubercle. Housed between the greater and the lesser tubercle is your intertubercular groove, also known as the bicipital groove. Okay, so that divides both the greater and the lesser tubercles. And it has the long head of the biceps that tends to run right in through there. The long head of the biceps runs right in through there. All right, and then so looking a little bit below now, where you have the intertubercular groove or the bicipital groove, we find the deltoid tuberosity, and we also find the radial groove. The deltoid tuberosity, that is on the lateral aspect of the upper 1/3 of the humeral shaft, and the distal tendon of the 3 heads of the deltoid muscle is going to attach there. You also have this radial spiral groove. It has an oblique look to it. All right, it goes oblique. We find this on the posterior surface of the humerus, and our radial nerve is going to run right in there. And that's going to help to also define the distal attachment for the lateral and the medial heads of the triceps. And so here we're able to take a look at the anterior view of the shoulder, and you're able to see all of the attachments or insertion points for many muscles. So just looking at the head of the humerus, just off of the anatomical neck, you'll see the subscapularis inserting at the lesser tubercle, your supraspinous muscle inserting at your greater tubercle. The intratubercular groove serves as also an insertion point for the latissimus dorsi. And you have your pectoralis major that runs in terms of an insertion point on the crest off of the greater tubercle, your teres major that runs off of the crest of the lesser tubercle. Our deltoid tuberosity, you're able to see that and see that this is where you have all three heads of the deltoid muscle inserting here. And then your coracobrachialis. Posterior view is reflected here in this particular slide. And so you're here able to see the infraspinatus that is inserting at the middle facet. We did not go over that in intro, but this would be the area known as the middle facet, coming off the posterior portion of the anatomical neck of the humerus. And then you have your teres minor that's going to be an insertion point here off of the lower facet as well. All right, you have your triceps, the lateral head, the insertion points we're able to see here. And then look, this is the obliquity that was referenced in the prior slide in terms of that spiral groove. All right, that spiral groove are also known as the radial groove, remembering that it runs obliquely across the posterior surface of the humerus. And so this is where you're going to see that the radial nerve is actually housed. Okay, and also here's where we're able to see much better in terms of the definition of the distal attachment for the lateral and the medial heads of the triceps. You will want to remember the four joints that actually make up the shoulder complex. That is the sternoclavicular, the scapulothoracic, the acromioclavicular, and then the glenohumeral joint. The sternoclavicular joint, we can see here in this picture, it's reflected with a circle and highlighted with a little bit of color where we can see its attachment with the manubrium. And so this sternoclavicular joint, it is created by the articulation of the medial aspect of the clavicle with the sternum. And what it does is provides the only direct bony attachment of the upper extremity to the actual axial skeleton. And so it remains incredibly stable while it is also allowing for mobility. So the sternoclavicular joint will want to know that allows motion in all three of the cardinal planes. You have your elevation and depression. You have your another cardinal plane, which is your protraction and your retraction. Okay, and then we also have the sternoclavicular joint responsible for the axial rotation. All right, it's supported by a thick network of ligaments. An articular disc is also there to house as like a pillow or a cushion between its attachment to the manubrium. And then you also have the joint capsule that solidifies and holds the clavicle down for all of those movements, those three cardinal plane movements. There's a high degree of stability, and that explains why if fractures are going to happen, it's going to happen on the distal portions of the sternoclavicular joint where it's actually less stable. When you have a fused sternoclavicular joint, that's going to limit movement of the scapula and also the clavicle. And then so if the scapula is going to be limited and the clavicle is going to be limited because the clavicle is limited in itself, then you're going to have the whole entire shoulder joint that's going to be limited as well. Some supporting structures to take note of at the sternoclavicular joint are your sternoclavicular ligament, the joint capsule, and the interclavicular ligament. So the sternoclavicular ligament that contains an anterior as well as posterior fibers, and it's joining the clavicle right there to the manubrium. The posterior portion is going to reinforce the capsule on the posterior side, and the anterior portion of the sternoclavicular ligament is going to reinforce the capsule on the anterior side. The joint capsule is what surrounds the entire sternoclavicular joint at the medial insertion point here at the sternum. Okay, and that's reinforced by an anterior and a posterior sternoclavicular joint ligaments. The interclavicular ligament, that's going to span the jugular notch. So that little depression that you have there at your sternum at the manubrium, that is your jugular notch. And so that's connecting the superior medial aspects of the clavicle, and it's going to limit clavicular depression. You also have your costoclavicular ligament as well as your articular disc as additional supporting structures. And so with the costoclavicular ligament, that's going to attach the clavicle to the costal cartilage of the first rib, and that's going to limit the extremes of any clavicle motion that's happening. Again, remembering that that medial section there of the sternoclavicular joint, that's very, very, very sturdy. Okay, and it's all of these ligaments that are there that's housing and keeping it secure and controlling that clavicular motion as well. The articular disc, that's going to absorb any shock that's happening between the clavicle and the sternum, and so that's going to help improve the congruency of the joint, just keeping it attached and keeping it fixed, or I should say keeping it articulating very close together. So here we have an appreciation of an anterior view of the sternoclavicular joints. You see some of the capsules and the ligaments are going to be removed on the left side so that we're able to take a further look at, say, for example, the articular disc, and also see a posterior bundle that would otherwise be covered up when you have your sternoclavicular ligaments covering over. All right, so we have the costoclavicular ligament, as you can see, attaching to the first rib there. All right, your sternoclavicular ligament with the capsule, and then your interclavicular ligament that's there at the manubrial notch, also known as the jugular notch too as well. And the articular disc that is there to cushion and pull more of an articulation, more of a congruency between the sternum and the clavicle. As we look at the kinematics for the sternoclavicular joint, this is an interesting joint in that it is a saddle joint. What makes it a saddle joint is that on each side of the articulating surfaces, so the clavicle side itself on the end of that clavicle, as well as the portion of the manubrium that articulates or touches or connects with the clavicle, both of those surfaces have a concavity as well as a convexity to them on their surface. And that's going to allow for the actual clavicle itself to move in three different planes. It's going to allow the movement to be in terms of elevation and depression, protraction and retraction, and then also that axial rotation. So during the abduction or during flexion of the shoulder, the clavicle is going to rotate posterior. It's going to rotate posteriorly, and it's going to do that along the longitudinal axis. All right, when the shoulder's abducting or when it's flexing, you're going to have the corticoclavicular ligament. It's going to be really taut. So that very steady portion there in the front is going to become very taut, and then the clavicle is going to spin posteriorly as a result. And so the clavicle is going to rotate also anteriorly and back to its resting position when the shoulder goes from adduction or when it goes into extension. Okay, you're going to find that on page 55 in your book in terms of the explanation that I just read. Here's an opportunity to look here. We see a schema or a schematic here of this saddle joint. We're looking at the right side, the sternoclavicular joint, and here we see it's been opened up and reflected back so that we're able to see these matching surfaces. Both the surfaces of the clavicle and the surface of the manubrium have a concavity as well as a convexity to them. Okay, a concave and lumbex portion of of the joint. All right, the clavicle in terms of elevation and depression. Okay, in terms of elevation and depression, the scapula is going to elevate, all right, and that involves the scapula sliding superiorly on the thorax, so when we shrug our shoulders. And then depression, that's going to occur when the scapula actually slides down inferiorly on the thorax. So when we're returning a shrugged shoulders to its resting position. And so that's going to depress the entire shoulder. All right, and this happens when we're actually doing a push-up as well from a seated position. So when we're teaching our patients how to do a push-up from a wheelchair, right, we're working with this elevation and depression of the scapula. More so, pushing up is going to be that depression of the scapula. And then the return back down to the seated position from that push-up is going to be an elevation of the scapula. Now the protraction and retraction, all right, this here you have the scapula actually sliding lateral on the thorax. So the scapula is actually moving away from the midline, okay? And then retraction, that's the movement where you're going to have the scapula moving towards the midline. So it's kind of like I would say to the patients, pinch your shoulder blades. Pinch your shoulder blades together. That would be the common language that would be used, all right, for the patient. Pinch your shoulder blades together, and that would be retraction. Now the rotation, you have upward and you have downward rotation. Okay, as stated before, the clavicle rotates on a longitudinal axis, so you'll want to know that. When the shoulder is moving into abduction, the clavicle itself is going to be spinning posteriorly. When you move the shoulder from a raised hand, like if someone's raising their arm up to the sky to ask a question, for example, when this person puts their arm down, okay, going into adduction, or if the shoulder is extended, for example, patients reaching into their back pocket, then the clavicle is going to rotate anteriorly at that point. Here in this schematic, we have an appreciation of the right sternoclavicular joint, and it's just showing the osteokinematic motion of the clavicle. So the clavicle, again, is going to move into elevation and depression, and when it does that, it's going to be in a frontal plane of movement, and that's going to be in an anterior-posterior axis of rotation. When we have here a protraction or a retraction happening of the sternoclavicular joint, so someone bringing the shoulders forward and then pinching their shoulders backwards, you have the motion happening in the horizontal plane, and it's going to happen about the vertical axis of rotation. When there's an axial rotation, this is an example of a patient moving the arm into abduction or moving their arm into flexion. And so that clavicle in any one of those two motions is going to rotate itself posteriorly. And the axis in terms of its rotation is the longitudinal axis. And then when the shoulder is going from the ADDuction, so that's ADD adduction or extension, what's going to happen is the clavicle then will actually rotate anteriorly back to its resting position. All right, now we're going to take note about the scapulothoracic joint. We want to know that the scapulothoracic joint is actually not a true joint in the traditional sense of what we come to understand of joints, joints having an articulation to them, a disc joining between them, okay, a cushioning of sorts. When we say scapulothoracic, we're really referring to that junction that's actually created by that anterior aspect of the scapula, and then that posterior portion of the thorax in which it glides on. And so typically, the motion of the scapula is described relative to its motion on the posterior portion of the rib cage. So how is it gliding? How is it moving? Okay, how is it elevating or depressing, retracting or protracting? All of that is relative to its movement on the posterior portion of the scapula. So when we talk about the scapulothoracic joint, this is what we mean. And so the scapular motion is allowed via the motion of the AC joint. Our acromioclavicular and our sternoclavicular is allowing, these two joints allow for the scapular motion to occur. Okay, so looking at the scapulothoracic joint in terms of motions, we have transitory movements that would be functional in nature, the elevation and depression, as well as the retraction and protraction. There are rotary movements, and so with the rotary movements, you have the upward rotation as well as the downward rotation. And so the upward rotation that's occurring as you have the glenoid fossa of the scapula is rotating upwards. And it's just a natural component of raising the arm over towards abduction or flexion. That's when you have an upward rotation. The downward rotation, that's going to occur basically when your scapula is returning from an upwardly rotated position, going back down to its resting position. And so that motion is going to naturally occur when you have the upper extremity that's elevated up in the air, just bringing it down back to its side. So that's an example of someone who's raising their hand to ask a question. The scapula is going from now an upwardly rotated movement. The person is going to put their arm down. As they're putting their arm down, that resting position is a downward rotating movement of the scapula. Also have anterior and posterior tilting of the scapula, and then you have an internal and an external rotation too as well. With the elevation and depression of the scapula, that's going to involve the scapula sliding posteriorly on the thorax. That's an example of shrugging the shoulders. The depression is going to be when the scapula slides inferiorly on the thorax, and you're just returning the shrugged shoulders to that rested position. Right, the protraction, the motion of the scapulae, meaning both scapulae, okay, they're sliding lateral to the thorax. The retraction, the movement of the scapulae, both of the scapulae are towards the midline in their motion. The upward rotation, that's going to occur as the scapula, as the scapular glenoid fossa rotates upward. The downward rotation is going to occur as the scapula returns from that upwardly rotated position to its resting position. Okay, so we have an opportunity to look here at the elevation and depression as when somebody shrugs their shoulders and then returns their shoulders back to a resting position. Elevation of the scapula occurs with the shrug, and then when they bring the shoulders back down, you have depression of the shoulders. If I give a patient an exercise called shoulder shrugs, we're working on scapulothoracic movement, improving the gliding, improving that. So exercises of shoulder shrugs is good for working on scapular elevation and depression. Here we have protraction and retraction. So when the patient has weakness, for example, of the rhomboids major and minor, and I want to incorporate an exercise that will allow for more movement, strengthening of that muscle, which thereby will also allow for more scapulothoracic protraction and retraction, then what I want to do is tell the patient to squeeze their shoulders, and when they squeeze, not squeeze their shoulders, but pinch their shoulder blades together, or like they're squeezing a ball that's centered at their back, then that's going to bring the scapula into the retraction. And then to bring the shoulders forward, we'll look at protraction too as well. Here you can see the upward and downward rotation. So your scapula is first at the resting position, and it's more of a downward rotation. Now when the patient moves into an abduction, okay, or moves into a flexion, what you're going to get is the upwardly rotated scapula. And again, what's the point of reference that we're using to understand upward rotation and downward rotation of the scapula? What is that point of reference? And how do you find it? How do you palpate to find it on your lab partner? Right here, we're looking at the osteokinematics that occurs of the acromioclavicular joint. And so what we can see that the axis of rotation, those are color-coded, okay? And those are color-coded with their associated planes, right? So we have anterior and posterior tipping. You also have your upward and your downward rotation. And then you have your internal and your external rotation that you're able to see here from the scapula and their associated planes. So here we have a lateral view of the scapula, and we're able to see the direction of the anterior and the posterior tipping. The two muscles that have strong influence on anterior tipping of the scapula would be the subscapularis as well as the pectoralis minor. If the lower traps are actually weak, then it's not able to oppose or balance that pulling of the pectoralis minor. So the pectoralis minor can appear very strong and have too much of a pull forward on the scapula, and the lower traps is unable to oppose that to balance the action. So what you can see is an anterior tipping of the scapula. You also have the serratus anterior that's there responsible for stabilizing the scapula across that thoracic cage there. So if you have a weak serratus anterior, what we really get is winging of the scapula. That winging of the scapula is a demonstration of a source of anterior tipping as well. We have the acromioclavicular joint. And so with the acromioclavicular joint, it's considered a gliding or a plane joint, and it's created actually by an articulation with the lateral aspects of the clavicle and the acromion process of the scapula. And so we'll want to make sure that we know how to find the acromioclavicular joint too as well, and we'll cover that in lab. So what the AC joint does is it links the motion of the scapula to the lateral end of the clavicle. Now, because you have really strong forces that are frequently transferring themselves across the AC joint, the acromioclavicular joint, you do have several important stabilizing structures, and these structures are required to maintain the structural integrity of the AC joint. So you have your acromioclavicular ligament, you have your corticoclavicular ligament, and which I'll talk on the next slide, the coracoacromial ligament. So with your acromioclavicular ligament, what this does is it joins the clavicle to the acromion and also helps to prevent any dislocations that are going to occur of the scapula and links motion of the scapula to the clavicle itself. Now the corticoclavicular ligament, this is actually composed of a conoid and the trapezoid ligaments, and we should see that in some subsequent pictures. Together, these two little ligaments, they're going to help to suspend the scapula from the clavicle and also prevent dislocation. And we have here the picture where you're able to see an anterior view of the right glenohumeral joint, and we're able to see all the surrounding ligaments that are present. So you can see here the conoid ligament and the trapezoid ligament that are part of the corticoclavicular ligament there. Okay, and you can also see the acromioclavicular ligament as well. We have a nice view here of the coracohumeral ligament, all right, and then that gapping space that is between the acromion and the humerus, we call that the subacromial space. The AC joint allows for motion that occurs in all three planes. You have in your frontal plane motion of your upward and downward rotation. And in your horizontal plane, you have the internal and external rotation occurring. And then you have in your sagittal plane anterior and posterior tilting of the scapula. Let me just go back to the part about the internal and external rotation in terms of the tipping. The scapula actually kind of just tips to the sides, if that makes any sense. And then with the anterior posterior tilting, it kind of tips up and down from a superior to a caudal direction, up and down, up and down. Okay, and tipping would be lateral. Okay, from each of the borders to the other neighboring borders. So the motions, which are what the AC joint allows for with the different planes of rotations and the tilting, what you have is an ability for these humerus and the scapula to fine-tune all of the motions that are happening, the multi-motions that are happening at the joint. And so the scapula, in essence, then is able to maintain a firm contact as a result to the posterior portion of the thorax. So here in this picture, we're able to see some osteokinematics happening here of the right AC joint. And then you see that the axes of rotation, those are color-coded with the associated planes of motion. So we're looking here, just to brief again. So you have your internal and your external rotation, and it's happening in the horizontal plane. You have your anterior and your posterior tipping, and so that is tilting, your anterior and your posterior tilting, that is happening in your sagittal plane, and then your upward and your downward rotation, this is happening in the frontal plane. Now, when you have protraction and retraction occurring, literally that is basically all the motions of both the sternoclavicular and the AC joints working together to create the motion of protraction and retraction. The full scapular protraction, what that's going to do is result in the glenoid fossa. It's going to actually face anteriorly with the full scapula in contact with the rib cage. The pictures below here, you can see the protraction going forward and the retraction moving backwards. What is meant by scapular plane when we say that? The scapula basically is just an anatomical position at this point. And so this anatomical position is really the normal resting position of the scapula that's sitting, lying on the posterior cage. So it's between 30 and 45 degrees coming off of the frontal plane. When we refer to scaption, that is the scapular plane of elevation. So a patient, as how you see here in the picture, holding a dumbbell, holding the arm in the scapular plane here down at the bottom, and moving into shoulder flexion in the scapular plane, okay, doing scaption, they're basically not doing a pure flexion and not doing a pure abduction. It's somewhere in the middle, okay? And so that's called scaption. And oftentimes we would definitely want to use this as an exercise for our patients to perform flexion in scaption, okay? It's, again, the resting position. It's a more comfortable position than the pure planar movement of flexion or abduction for our patients. So you can train your patient in flexion with a particular exercise. That's fine. You can train your patient in abduction with a particular exercise. You can also, with a functional, right, position in terms of elevating the arm, use the anatomical position and scaption in the scapular plane to perform the flexion too, as well as how you see here in the picture in the middle. Okay, the glenohumeral joint has an articulation of the humeral head, and that's going to join with the glenoid fossa of the scapula. We're going to get lots of motion in all three planes happening at the glenohumeral joint as a result, and there's not a lot of stability that's there. The rotator cuff muscles, they're there to provide that primary stabilizing force in this joint. So you want to know that the rotator cuff muscles are there to provide the stability of the glenohumeral joint, because there's a lot of motion happening at the glenohumeral joint that does not allow for stability. So we need those muscles to hold it down. All right. right, so the supporting structures of the glenohumeral joint that's going to hold that humeral head into the glenoid fossa are your sits muscles, and that is your rotator cuff, which are and comprising of the supraspinatus, the infraspinatus, your teres minor, remember it is the minor, and then your subscapularis, also known as your sits, S-I-T, S minor muscles. So you just want to remember that for your teres, that this one is your minor. I used to use an acronym TIM in the middle. Okay, so that would remind me of the teres minor for the MI for the minor. All right, additional supporting structures you have are the glenohumeral joint capsule and the coracohumeral ligaments. So in terms of the glenohumeral joint capsule, it is a thin capsule, and so it includes a superior, middle, and an inferior glenohumeral ligament. And so this attaches between the glenoid fossa and the rim of the humeral neck. The coracohumeral ligament, it has an attachment between the coracoid process and the anterior side of the greater tubercle. And with this enacting ligament, it's going to limit external rotation, flexion, extension, and inferior displacement of the humeral head. The glenoid labrum, what happens with the glenoid labrum is that it is a fibrocartilaginous ring, and that's going to encircle the rim of the glenoid fossa. So the labrum, what it serves to do is just to deepen the socket of the glenohumeral joint. And so that labrum is going to help to then also seal the joint and contribute to a stability of maintaining a slight suction effect that occurs between the humerus and the glenoid fossa. Then you have your long head of the biceps, and so the proximal portion of the biceps is going to attach to the superior glenoid tubercle and give stability that will be there for the anterior stability that's required at that joint. This slide is blank, but what you should have printed on your handout actually is the figure 4.12 from page 58 in your book. And it is just showing you the coracoclavicular ligament, also the coracoacromial ligament, the acromioclavicular ligament too as well, and the capsule ligament, as well as the coracohumeral ligament, so that you can see where they lie. Here we have a picture of our sits muscles, our rotator cuff muscles, your supraspinatus, your infraspinatus, your teres minor, and your subscapularis. You see those here holding in the humeral head, okay, offering stabilization to the glenohumeral joint. Okay, and then here at the bottom, this ventral view, what we're able to see is the coracoclavicular ligament, as well as some other ligamentous structures too as well. We're able to see the deepening here of the glenoid cavity and how that offers a suctioning effect for the glenohumeral joint into the stabilizing structures of the scapula. So in this picture, we're able to see the glenohumeral joint with muscles, the rotator cuff present, as well as the biceps and the deltoid. And patients can end up with what's called a subacromial bursitis, and that is when this bursa that sits right underneath the acromion and right on top of the head of the humerus, that bursa is there to help the muscles to glide so that there's no restrictions, compression, or pain. But there are some times when the patients have instability, or when that bursa can actually get compressed up underneath the acromion, and then that'll cause a bursitis. We can try and alleviate that by having the patient to slightly externally rotate the glenohumeral joint. And we'll show you this. We'll talk about this also in Therex 1. All right, so they externally rotate the shoulder when they're performing the abduction in the scapular plane, and that's going to take any pressure basically off of the tight structure space that's happening under the acromion. So we need to be careful when we're giving our patient exercises not to compress the joint. A way to avoid that would be to have motion in scaption as well as externally rotating the glenohumeral joint. So thumbs are usually at the side. You want to rotate where the palm is facing anteriorly, and that's externally rotating the forearm, and that's going to take up the space in terms of take the slack off and prevent impingement. All right, so here we talk about the kinematics. You have a ball and socket joint for the glenohumeral joint. There are 3 degrees of freedom: flexion and extension, abduction, adduction. You have horizontal AB deduction and horizontal AD deduction, as well as internal rotation. And then you can get circumduction. Circumduction is considered like a circular motion. It's a combination of the flexion, the extension, the abduction, as well as the adduction too. All right, so let's talk about glenohumeral joint in terms of abduction and adduction. Well, abduction, adduction occurs in the frontal plane, and you have the glenohumeral joint itself. Just the glenohumeral joint is going to be responsible for 120 degrees of the abduction. Then the rest from 120 all the way to 180, that difference is 60 degrees. That difference of the 60 degrees, that's pure scapular upward rotation that's happening. And so we call that the scapulohumeral rhythm. All right, there's a 2-to-1 ratio with the scapulohumeral rhythm. So you have 120 degrees plus 60 degrees. That's going to give you your 180. And then 60 degrees is coming from, those last 60 degrees is coming from the upward rotation of the scapula. All right, there's conversations about this on page 60 of your book. Page 59 it begins, and then moving on to page 60. And it's just letting you know that there is a 2-to-1 ratio in terms of the rhythm with the glenohumeral joint and then also the scapulothoracic joint. So for every 2 degrees of glenohumeral abduction, you're actually getting about 1 degree of rotation that's happening upwardly with the scapula. What I want you to know is that there's a 2-to-1 ratio. The first 120 degrees, which is your 2, all right, is purely glenohumeral abduction movement that's happening. And then the last 1/3, which is 60 degrees, to get to the 180, that is your scapulohumeral, okay, rhythm that's occurring. Okay. All right, now in terms of rolls and glides when the abduction and adduction is occurring, so with abduction, you have your convex head of the humerus that's going to roll superiorly, and then at the same time, your glide is going to be inferior. And it is the opposite when we talk about adduction of the glenohumeral joint. So what you have is that the humeral head is rolling inferiorly, and then at the same time, it's gliding or sliding superiorly. When there's impingement, what you have is an upward humerus is rolling, and that humeral head gets jammed into the acromion. So there's no inferior slide that's able to happen to allow for the gapping of the space. Instead, it gets just jammed up into the acromion. So here we have a picture, just giving a little bit more description and meaning to the text from the prior slides. When an impingement is actually occurring, or this is actually the absence of an impingement, this is what normal scapulohumeral rhythm is occurring. Okay, so when you have proper arthrokinematics of the glenohumeral joint, what happens is you have that inferior slide when the arm moves into abduction, okay, as the arm moves into abduction, you get this inferior slide so that glenohumeral head is able to come down some. By it coming down, right, your roll, you get a roll that goes superiorly, and that's going to allow for the bursa to not get jammed up into the subacromial bursa, to not get jammed up into that tight space. So that preserves the supraspinatus as well as the subacromial bursa. Now this is the picture of actually an impingement that's occurring when the inferior glide, okay, is not allowing to happen. So patient is still moving into the abduction, but if the inferior glide, which happens down this way, does not occur, then what happens is the humeral head gets jammed up, as you can see here, compressing the subacromial bursa as the supraspinatus muscle pulls into the abduction. So both the impingement on the supraspinatus as well as the subacromial bursa, and the patient has pain. By putting the patient in scaption, we also avoid having this problem too as well. So for the flexion and extension, that's going to occur in the sagittal plane. And here the humeral head is going to spin on a fixed axis. You get about 120 degrees of flexion and then about 45 degrees of extension that's available for the shoulder. The 180 degrees of flexion at the shoulder, that's going to be by using 60 degrees also of the scapular upward rotation. So the scapular humeral rhythm does still go into play with flexion as well. 2-to-1 ratio, 120 glenohumeral, last 60 degrees is the scapular. Okay, and so we have internal and external rotation. Okay, so that's going to occur in the horizontal plane, and that's going to happen about the vertical axis of rotation. So the internal rotation, you have the anterior surface of the humerus is going to rotate medially, and then with external rotation, the anterior surface of the humerus is going to actually rotate laterally. So you have this convex humeral head, it's going to roll and slide in opposite directions on that concave glenoid fossa. All right, so for your horizontal AD deduction and horizontal AB deduction, for your horizontal AD deduction, you're getting movement of the humerus, and that's going towards the midline in the horizontal plane with the shoulder in about 90 degrees of abduction. Then you have your horizontal AB deduction. It's just going to go in the opposite direction. So it's going to move away from that midline in the horizontal plane. Now, when we get interaction among the shoulder complex joints, you have movement of the entire shoulder, and that's going to occur in each of the 4 joints. And so all those 4 joints relate in having normal shoulder motion. And so scapulohumeral rhythm is an example of having all of those motions occur. Now, there's something called scapular dyskinesia. When there is scapular dyskinesia, you get an alteration of the alignment. So the normal position of the scapula, it's altered a little bit during the normal motions. And that's called scapular dyskinesia. So the scapulohumeral rhythm, well, what is that? When you have normal shoulder abduction, again, you get a natural 2-to-1 ratio of a rhythm that exists between the glenohumeral joint and the scapulothoracic joint. And so that's what's going to give optimal function of the shoulder. So with the shoulder abduction or flexion, that 2-to-1 ratio must exist. And that's every 2 degrees of abduction, you're going to have 1 degree of the scapula rotating upwardly at the same time. Or if you're doing shoulder flexion is the other option, you still get a scapulohumeral rhythm where for every 2 degrees of the glenohumeral flexion, the scapula is still at the same time going to upwardly rotate, and it will do this by 1 degree. When you have this scapulohumeral rhythm, it is able to perform the last 60 degrees of the upward rotation with the assistance of the acromioclavicular and also the sternoclavicular joint. All right, so what's important to know here is that the scapulothoracic joint, it has to use parts of the AC joint and the SC joint in order to accomplish the last 60 degrees of the scapulothoracic rhythm of upward rotation. All right, it's borrowing about 30 degrees from both in order to make that combined 60 degrees of scapulothoracic movement, which is upward rotation. So here in this picture, we are able to see, this is coming from page 60 in your book, and it's a posterior view of the right shoulder complex. Okay, this is after the arm has already been abducted 180 degrees. So you're able to see 60 degrees of the scapular upward rotation and 120 degrees of the glenohumeral joint abduction. All right, those are the ones that are shaded in the purple. And in order for the scapulothoracic joint to have this 30 degrees of motion, what it needs to borrow is from movement that's coming from the AC joint, okay, as well as movement that's coming from the sternoclavicular itself as well. All right, so when we get 30 degrees of movement here and about 30 degrees of movement coming from here as well, okay, the sternoclavicular joint and the AC joint, then the scapula itself is able to rotate upwardly a total combined of 60 degrees. This slide is talking about the bony movements that happen during common shoulder motions. And this is coming from box 4.1 on page 60 in your book. And so looking at, for example, horizontal A deduction. Well, with horizontal A deduction, what happens? You get horizontal AD deduction of the humerus. And then in terms of the scapula is going to move into a protraction of the scapula and then also a protraction of the, of the clavicle. Horizontal AB deduction, what you're going to get is horizontal AB deduction of the humerus, and you're going to get retraction of the scapula and retraction of the clavicle. For the shoulder flexion, remembering that there's the scapulohumeral rhythm that's happening there at a 2-to-1 ratio. It's really important to remember of that glenohumeral flexion. And then you have the scapulothoracic joint that's going to go into upward rotation. Very important to remember. So you're having flexion of the humerus, okay, that's a component of shoulder flexion, but also you're getting an upward rotation of the scapula and also an elevation and superior rotation of the clavicle with the shoulder flexion. In terms of the shoulder extension, you get the same kinematics depending on the range through which the shoulder is going to be extended. So what you get here with extension is the humerus is going to move into extension, and then you're going to have a downward rotation and a retraction of the scapula. There's also going to be a depression and retraction of the clavicle. With the shoulder abduction, all right, there's a 2-to-1 ratio happening as well. And so you're going to get an AB deduction of the humerus, and then you're going to have an upward rotation of the scapula, and then that's going to follow by a clavicle elevation and posterior rotation. Okay, let's talk about innervation now of the shoulder complex. You have the brachial plexus that's going to go ahead and innervate the entire upper extremity. And so the majority of that shoulder complex muscles are going to come from two of the brachial plexus regions. You're going to have nerves that branch from the posterior cord and then the nerves branching from the more proximal segments of the plexus. You do have some exceptions like the trapezius muscle, which its innervation is actually innervated by the primary cranial nerve number 11. So here we have the brachial plexus. Now you want to remember that the entire upper extremity is going to receive information primarily through this schema that you see here, which is the brachial plexus. This brachial plexus you can find in figure 4.17 in your book on page 63. And so the brachial plexus, remembering that it's formed by a network of nerves from the spinal nerves, from C5 to T1, and then the nerve roots from C5 and C6. Those are going to form the upper trunk. And then you have C7 that's going to form the middle trunk. And then you have C8 and T1. Those are going to form the actual lower trunk. And so those trunks are going to travel a short distance before those actually form anteriorly or posteriorly, making divisions that are anterior and posterior divisions. Those divisions are going to reorganize themselves again and then go to a lateral, a medial, and then posterior cords. And so those lateral, medial, and posterior cords, those are named by the position relative to the axillary artery. The cords, eventually they're going to branch into nerves that primarily innervate muscles of the upper extremity. And so most of the muscles of the shoulder complex are going to receive their innervation from the two regions of the brachial plexus. Again, nerves that branch from the posterior cord, and that's, for example, the axillary, your subscapular, and your thoracodorsal nerves. And then two, nerves that branch from the more proximal segments of the plexus. And that can be your dorsoscapular nerve, for example, your long thoracic nerve, your pectoral, your suprascapular nerves, etc. There is an exception in terms of innervation. You do have your trapezius muscle. All right, that's actually innervated by the cranial nerve number 11, which is your spinal accessory nerve. Okay, let's take a look at the muscles of the shoulder girdle now. So the muscles of the shoulder girdle are basically the scapula and clavicle, muscles that encase the scapula and the clavicle. And so those muscles are going to control the shoulder girdle, and they each have proximal attachments that go to the axial skeleton, and they have distal attachments that go to the scapula, or they can go to the clavicle. These muscles are going to function mostly to position the scapula, okay, so that it can optimize the function of the shoulder as a whole. All right, we'll take a look here at the muscles of the trapezius. We have our upper, middle, and lower trapezius reflected in this picture. For the upper traps, you have its origination at the occipital bone and the nuchal line, the spinous process of C2 to C6, and originating at the lateral third of the clavicle in the acromion process. Middle traps, you have origination at the spinous process of C7 to T3 by some sources. Your book has from C7 to T5, so we'll go with that of your book. Your insertion for the middle traps is the spine of the scapula. The lower trapezius is going to originate on the spinous process of T4 to T12, and then it's going to insert at the base of the scapular spine. And so your book actually has the proximal attachment as T6 to T12. And so we'll go with what your book says. Some other sources may have different. And you can see also the discrepancies can be based on just anatomical. Some people, theirs may be a T4 or T6. All right, the action is we have elevation of the scapula, all right, and upward rotation of the scapula with the serratus anterior and the lower traps. That's for the upper traps. And for your middle traps, you have the action is going to be to retract the scapula. And then for the lower traps, the action is going to be to depress the scapula, have upward rotation of the scapula as well, and retraction of the scapula. Okay, here we're taking a look at the levator scapula and also the rhomboids. So the origin of the levator scapula is going to be the transverse process of C1 to C4 and inserting at the medial border of the scapula between the superior angle and the spine. And for the rhomboids, going to have an origination of spinous process C7 to T5, and the insertion is going to be the medial or the vertebral border of the scapula between the spine and the inferior angle. And so the action for the levator scapula is to elevate the scapula and then downwardly rotate the scapula. Action for the rhomboids is to retract the scapula, elevate the scapula, and also work with downward rotation of the scapula. So again, you're going to need to know the origin, the insertion, as well as the innervation of all of these muscles. All right, our serratus anterior. Serratus anterior, we can see here, all right, you have the origin to be the lateral ribs. Okay, the lateral upper 9 ribs, so 1 through 9. And then you have your insertion at the vertebral border of the scapula and the anterior surface. All right, innervated by the long thoracic nerve. Long thoracic nerve. I'm reading this from page 66. Next, we have the subclavis and your pectoralis minor. And so your subclavis originates from the first rib and inserts on the subclavian groove of the clavicle. The pectoralis minor originates at the anterior surface of ribs 3 through 5 and inserts at the coracoid process. And this is again the pectoralis minor. All right, so let's talk about scapulothoracic joint elevators. What muscles are responsible for that? Okay, so we have the upper traps, you have your levator scapula, and the rhomboids are going to be elevating the scapula. And so when we want to have and think about scapulothoracic posture, a good posture would be when the scapula is actually slightly retracted. There's a little bit of an elevated position also happening to the scapula. And we see that the glenohumeral fossa is facing upward. Some of the functional considerations that we want to incorporate, okay, that's going to, if we're not careful, it's going to likely lead to like a depressed and downwardly rotated scapula, okay, over time. When you have that depressed and that downwardly rotated scapula, well, the consequence of that is that it can lead to a superior dislocation of the sternoclavicular joint. And then the lateral end of that clavicle is going to be excessively lowered. All right, and that's just going to cause problems that's happening at the underlying first rib. Okay, so some of the weaknesses of the upper traps, well, when there's a paralysis, which is a weakness of the upper traps, again, you're going to get that depressed and downwardly rotated scapula. All right, chronically depressed and rotated scapula can lead to a dislocation of the sternoclavicular joint. More commonly, we do see weakness in the upper traps, that leads to a subluxation of the glenohumeral joint. We do see that from a neurological perspective in terms of diagnoses. Like, for example, a patient that has a stroke, all right, they end up with the weakness of that upper trap, that paralysis of the upper trap, and then over time that upper trap is going to lead to a depression. It's going to then downwardly rotate the scapula. And the shoulder, the glenohumeral joint itself, has a propensity and can sublux. And the patients do tend to complain of shoulder pain quite frequently. A sling helps for that, having approximation at the sling. Approximation at the glenohumeral joint with the sling. All right, so we have depressors. What are depressors of the scapulothoracic joint? For the scapulothoracic depressors, that would be the lower traps, your lats, your pec minor, and your subclavus. Those are going to be your scapular depressors. When they work together, they're going to depress the shoulder girdle. They're also going to depress the humerus, and you're going to get shoulder depression as a result. Now, this is an important slide. You'll be asked a question from this. This slide basically is just showing you when a patient's actually pushing off from the chair. So let's say that we have our patient performing wheelchair push-ups. They're pushing up from the armrests of the wheelchair. All right, and so you see the force coupling action happening from the lower traps, also the latissimus dorsi. Okay, that force coupling action that's happening there is going to work together, and we're going to get a depression of that shoulder girdle and of the humerus, and that's going to result in scapular depression. So let me ask you, what coupling force muscles work for chair push-ups or for scapular depression, for example? And you'll need to be able to tell me it's the lower traps and the latissimus dorsi, for example. All right, some of the functional considerations when we look at the reverse action of the shoulder depressors, we can have that very useful, okay, for the thorax elevation activities. And so when a patient needs to use the crutches or ambulate with a walker, we're using the reverse action of the scapular depressors. And so those muscles, they can become useful for substituting. There could be a weakness that the patient has in the sense of the lower extremity, and so you need for the upper extremities to substitute, all right, to be able to carry the limb, carry the body weight forward. So the way that can be done is when you have somebody who has a weakened or paralyzed lower extremity, the humerus, you have that stabilized on a weight-bearing crutch. Okay, so basically that means that the hands are gripped on the arm grips of the crutch. And then when the person is lifting their body up to swing through the legs, you have the lats substituting as well as a hip hiker, but you see that there's this reverse action of using the shoulder depressors to propel the body forward. And so here we see an example of actually the reverse action. And what you have are here the lower traps and the lats working in a reverse manner. All right, to be able to lift, as you can see, to lift the sacrum up off the chair. That's functioning in the same way as how we use the crutches. Crutches are going to lift our hips from away from the floor, so that means lifting them up and away so that the upper body can carry the lower limb to advance the lower limb forward if the lower limb happens to be weak and no advancement or minimal advancement can be done from the lower limbs. All right, let's talk about upward rotators of the scapula. Okay, so the upward rotators of the scapula, you have you have this force couple that's occurring with the serratus anterior, the upper traps, as well as the lower traps. So that's really important to know, the force couple. Right? That's just the action of all three of those muscles, the serratus anterior, the upper traps, and the lower traps, them working in unison, three, okay, together. And when they all pull based on where they're attaching to the scapula, they're going to have like a coupling. So it's going to go in this coupling motion. All right, so they're lines of pulls because they're different. What they're going to be doing is rotating the scapula, but because they're all pulling in different directions at the same time, the scapula is going to rotate in one direction. So this is an important slide here. All right, so when we're looking here at the driving motion, all right, so when someone is driving, all right, and say you want to turn the steering wheel, all right, the turning of that steering wheel is a forced coupling action that's occurring also between the upper traps, the lower traps, and the serratus anterior. And what you can see in this pic is each of those muscles, independent of themselves, all have a line of pull in a certain direction. But when they're all working together to pull at the same time, what you get is an ability, for example, for this patient to be able to turn the wheel. And that's very functional, very, very, very functional in terms of being able to turn and drive, steering of the wheel. So if our patients have weakness and difficulty unable to steer the wheel, the muscles that we work on strengthening are the upper traps, the lower traps, and the serratus anterior. But they must work also in unison, right, in order to have and produce the coupling force that will be appropriate for turning the steering wheel. All right, so here is another example of a forced couple. And so in this example, you're looking at the deltoids, the supraspinatus, and the subscapularis, the infraspinatus, and the teres minor. And so you'll need to know that with abduction, okay, with abduction, you're getting an inferior slide. All right, that's what you'll need to know. Okay, you'll need to know that those muscles, the deltoid, the supraspinatus, subscapularis, infraspinatus, and the teres minor, are also examples of force coupling, but for the motion of abduction. All right, so our scapular protractor is the one and only serratus anterior. All right, and so what that does is it generates a force so the scapula can actually move away from the bony midline or the body's midline. All right, and so the force that's coming from the serratus anterior that goes through the scapula to the humerus, all right, when we're actually reaching forward for, say, a cup or pushing something, that's the example of our serratus anterior that's actually working to produce this type of movement. And here what you see is a picture that is showing us where the serratus, reminding us where the serratus anterior is. This red arrow is basically showing your patient that's holding the arm up to 90 degrees first, and then keeping the trunk straight, not leaning forward, but keeping it straight, and using the hands to push forward. Using the hands to push forward. It's like if the patient's trying to reach forward without flexing or moving the trunk at all. And that's pure serratus anterior. This is an open chain picture of what you see here in this slide. A closed chain motion of that same activity is actually a push-up. Same exact thing. All right, so you're seeing the line of pull, all right, showing that it's protracting the scapula. Okay, the patient is in a forward reaching and pushing motion of sorts. All right, you can start the slide. Very important to know, winging of the scapula. So when there is winging of the scapula, what's happening here is the medial border of the scapula is lifting away. If you remember, we have the serrati, okay, that are attaching there actually. And so the weakness of the serratus muscle the serratus anterior, is going to result in what you see here with these patients, which is a winging of the scapula. And what nerve innervates the scapula? Excuse me, what nerve innervates the serratus anterior? You're going to need to know that. All right, here what we have next is when there is a presence of the winging of the scapula, we can have rehabilitation programs that strengthen that serratus anterior. So we have a closed chain exercise, which is a push-up here. Okay, and that's going to involve additional protraction of the scapulae, meaning both of the scapulae, all right, at the end of the phase of the push-up. The downward rotators of the scapula. All right, our downward rotators of the scapula are your rhomboids, the pec minor, and the latissimus dorsi. Very important. It's also underlined here for emphasis. All right, so your lats and your rhomboids, of course, they have different lines of pools together. They're producing this rotary action. All right, and so what we have here in this picture is looking at the force coupling of the rotary action for that scapulothoracic downward rotation that's happening with glenohumeral AD deduction. As the arm pulls down, still a closed chain movement here, but the arm is pulling down, and the very different lines of pulls all working together is forming the scapulothoracic downward rotation. Retractors of the scapula. All right, so when we're pinching the shoulder blades together, all right, we're using primary scapular retractors, which happen to be the rhomboids and the middle traps. You can use all three trap muscles too for scapular retraction. And here in this picture, we're able to see when retraction is being done. Okay, you have the lower traps that are pulling, you have the rhomboids, and you also have the middle traps that are pulling, and all together is going to bring the scapula towards the center of the spine. All right, so for the next few slides, we'll have all the way to, it looks like slide number 98, I believe, is the origin and insertion of muscles. You can find these as a continuance, actually, on page 'Actually, let me find it here. Okay, finding it here on page 73. All right, so here we have the supraspinatus. All right, the origin is the supraspinous fossa. The insertion is the greater tubercle of the humerus. It's innervated by the suprascapular nerve, and it performs shoulder abduction and stabilizes the glenohumeral joint. Okay, here we have the infraspinatus and the teres minor. And so the infraspinatus originates in the infraspinous fossa and inserts at the greater tubercle of the humerus. And then you have your teres minor originating at the axillary border of the scapula and inserting at the greater tubercle of the humerus. All right, you're going to get a lateral rotation and horizontal AB deduction with these. Next we have here your subscapularis. All right, so we're looking at an anterior view here to be able to view the subscapularis muscle that's originating here in the subscapular fossa of the scapula and inserting, as you can see here, at the lesser tubercle of the humerus. And medial rotation is the action. We have here the latissimus dorsi, and it originates from the spinous process of T7 all the way to L5. All right, and then it's also going to insert on the medial floor of the bicipital groove. And its action is adduction, extension, as well as medial rotation. And then we have here the teres major originating from the axillary border near the inferior angle and inserting distal to the lesser tubercle. Its action is adduction and medial rotation. The next one that we have here is the biceps brachii. All right, so for the biceps brachii, remembering you have a long head and a short head. So for that long head, it's going to originate at the supraglenoid tubercle of the glenoid fossa, and then your short head is going to come right off that coracoid process of the scapula. Okay, its innervation is the musculocutaneous. All right, the insertion is the radial tuberosity. All right, and this is going to flex the shoulder, extend the elbow, and also supinate the forearm. Okay, you have the coracobrachialis. So your coracobrachialis, its action is going to be for shoulder flexion, and its origin is on the coracoid process of the scapula, inserting on the medial surface of the humerus near the midpoint. All right, and as I go forward, remember guys, you just have to study these muscles. This is one, get your note cards out, use your pictures in the book, write down the origin and write down the insertion, as well as the nerve innervation, because you will be asked and you need to know them. The only way to learn them is to really just get right down and opening up your book, studying, looking at your flashcards and using them as well. Here we have the triceps. All right, so let's just talk about the long head of the triceps. All right, so you have your origin at the infraglenoid tubercle of the scapula and insertion at the olecranon process. Okay, let's talk about your deltoid. The anterior deltoid, middle, and posterior deltoid. For your anterior deltoid, their origins are going to be the lateral surface of the clavicle. The middle deltoid is going to be the acromion process, and the posterior deltoid is the spine of the scapula. All of those are going to have a common insertion point at the deltoid tuberosity. What is the innervation of this muscle? And what is the action? All right, you have your pectoralis major here. We're able to look at both portions. All right, so for the clavicular portions, you're going to have an origin that's going to be at the medial third of the clavicle and also inserting at the lateral bicipital groove. The pec major has a sternal portion, and so for that sternal portion, it's going to be the sternum and the costal cartilages of the first 6 ribs, and same insertion point, which is the lateral tip of the bicipital groove of the humerus. All right, you have your glenohumeral joint muscles, which are your abductors and your flexors that we're going to talk about right now. And so for your abductors, that's going to be your supraspinatus and your anterior and middle deltoid. The flexors are your anterior deltoid, the clavicle head of the pectoralis major, and the coracobrachialis and the biceps brachii. So here we have a picture on the next slide. This is a picture of the action of abduction. All right, and so you can see here with the AB deduction, you have your anterior and middle deltoids that are assisting along with the subscapularis in order to be able to AB deduct the arm or move the arm away from the body. All right, we have our AD deductors and extensors. Okay, so your AD deductors and extensors is going to be start with your AD deductors. That's your teres major, your lats, and your pectoralis major. And the extensors are going to be the lats as well, your teres major, the pectoralis major, the posterior deltoid, and the long head of the triceps. All right, the rotator cuff. I talked about this earlier, but this is a nice reminder again that it's your sits muscles, as we have it written here: supraspinatus, infraspinatus, teres minor, and subscapularis. All right, what they're going to do is surround the humeral head anteriorly, also at the top, and then posteriorly, and really hold that glenohumeral joint and then stabilizing it, stabilizing the head into that glenoid fossa. And so its function, these rotator cuffs, they stabilize the rotator cuff, the shoulder, the glenohumeral joint. And here is a schematic of those muscles in action. You have the pool of the supraspinatus and the infraspinatus and the teres minor, okay, all working together, all right, to stabilize. All right, so here we have an example here of a force couple of different lines of pools working together. So you have the supraspinatus, it's going to pull. You have the anterior deltoid, and you also have the subscapularis and infraspinatus and teres minor. So I did mention this earlier, so it looks like there's just another notation about that you'll want to know. Okay, the muscles, the force coupling muscles, to produce that abduction motion of the glenohumeral joint. All right, and we have, looking again just at our rotator cuff, just able to see here from an anterior view, the subscapularis. And then from the posterior view, you can see the supraspinatus, the infraspinatus, the teres minor as well. This slide is just going over your internal and external rotators. You'll want to remember that your internal rotators are your teres major, pectoralis major, subscapularis, your lats, and the anterior deltoid. The external rotators are the glenohumeral joints for the teres minor, the infraspinatus, and also the posterior deltoid. Now, this is an important slide. So it's at the back, but very important. You're going to be asked a multitude of questions coming from this particular chart. And as Mr. Pinzone did go over the roles in the slides, the principles now are coming into play for the shoulder. And this will be similar for every joint moving forward, for the elbow, the wrist, and the hand. But in terms of the physiological motion that's happening at the humerus, when we're looking at flexion, for example, you want to see the spin, and you want to see where the rolls and the glides or the slides are going. So flexion, for example, there's a spin, you get an anterior roll, okay, and you also get a slide that's posterior. And so for AD deduction, you have an anterior roll and a posterior slide. Your internal rotation, all right, when you start at 0 degrees of AB deduction, you get an anterior roll and a posterior slide. So you're going to want to go through these. You will have to know this chart. I will ask you, for example, horizontal AB deduction, what kind of roll and slide happen or occur with this particular physiological motion. All right, and then here is a chart that is explaining basically the degrees of motion that happen at the shoulder joint. Flexion is 180, AD deduction is 50 to 75, and you have extension 0 to 60. Abduction is 180, medial rotation is 70, lateral rotation 90. All right, and horizontal ABD, what's happening there? You have 45 degrees. Horizontal ADD is 130 when we start at 90 degrees. You will need to know the capsular patterns. All right, so the capsular pattern. Remember, the loose pack position is where the joint is the most relaxed, or the position of least congruency. All right, you want to think of it as the gapping, as the breathing space for the joint, where there's minimal surface contact. All right, and so where there's minimal surface contact, that's also a great place to perform joint mobilizations, because you won't have the bone grinding up on any articulating surfaces and causing further breakdown and degradation. Now your closed pack position, this is where the joint capsules are going to come together, maximally tense. So the capsule itself is going to be with maximal content and very, very tight or taut. So you don't want to do joint play during this. It's nearly impossible anyways to do it. You just need to have that laxity to be able to play with the joint up and down and glide it side to side, or whatever is indicated for that particular joint in terms of manual therapy. Okay, you have a capsular pattern. The capsular pattern, all right, this is super important. You want to star this. You'll need to know the capsular pattern. What is a capsular pattern? When we have the limitations of movement at a specific joint, let's say the shoulder, for example, okay, there's going to be certain movements that we see of the shoulder joint more in certain planes than other, for example, in certain motions than in others. So let's say, for example, what happens with glenohumeral joint motions when there is a capsular pattern, when there is an injury, when there's a structure that's limiting the movement of the shoulder joint itself, what we see is that flexion is the least limited of the movement, and external rotation is the most limited of the movement. So you'll see the patient first will have very little external rotation, and then next after that is going to be flexion that's limited. And so here with this last slide, what this is going through, you're going to need to know this. You want to start the slide and really start from today, really getting that down, is the loose pack positions and the closed pack positions, as well as the capsular pattern for the glenohumeral joint, as well as the acromioclavicular joint. Okay, so loose pack position, you put the patient's arm in 55 degrees of AB deduction and 30 degrees of horizontal AD deduction, and you'll have the joint opened up in the most space, the most gapping, in order to be able to perform joint mobilizations. Closed pack position is adduction and the lateral rotation of the humerus. Capsular pattern, if there is a problem, okay, that's happening with the capsule, maybe an internal derangement, but anything where there's issue with the capsule, you're going to have lateral rotation is going to be limited most, and then abduction will be limited next, and then medial rotation will be limited. Okay, and then just a reminder of the active and passive insufficiency. All right, this is going to be on your exam too as well, so please make sure that you are studying adequately. All right, so for the upper extremity, you have your biceps. When they are with active insufficiency, you're going to have basically the shoulder and the elbow is going to be flexed. Your forearm is going to be supinated. So it's going to be maximal contraction of the biceps, which is going to cause flexion at all those joints, shoulder and elbow flexion, all right? Also forearm supination. Passive insufficiency is going to be in the opposite direction. So the shoulder is going to be extended all the way, then elbow extension extended all the way, and more passive efficiency for the muscle. Get it on that full lengthened position will be pronation at the end. All right, your triceps brachii. The triceps brachii in active insufficiency is when the shoulder is extended and the elbow is also extended. Passive insufficiency would be in the opposite motion, to put those tissues on slack. All right, on slack or in a lengthened position, you'll have the shoulder and the elbow both will be in a flexed position. Okay, you want to study very hard for the shoulder. It's very imperative to read the book. Your answers, your conversations, your thought process is all coming from the book.